All right, guys, well, welcome to this pharmacology drug class review on anti-lipemics or lipid-lowering drugs that are specifically targeting LDL. We're going to be talking about the HMG-CoA Reductase Inhibitors, also known as the statins. In this session, I'm going to explain why HMG-CoA Reductase Inhibitors matter in a way that is easy to understand, clinically relevant, and especially in the context of LDL lowering and the evidence. Now, we know that this drug class matters because its use in clinical practice is based on a lot of evidence, both in primary and secondary prevention of coronary heart disease that support their use. And with that, I'm Dr. Busti. Thank you for joining us on This Is Why, a show dedicated to helping healthcare professionals understand the why behind the pharmacology and the drugs that we use. Because when we understand the why, the how becomes easier, doesn't it? The mechanism starts to make sense of the therapeutic and desired effects, our goals, but it also explains sometimes side effects, contraindications, monitoring parameters, counseling points that are patient specific. Now, with all of my drug class reviews, we cover core content because that's the reality. We all have to learn the agents, the indications. Why are we using or picking this drug class? Then what is the pharmacology in the context, especially also of other agents that I could choose to lower LDL? And then we migrate over to that clinical application. In this drug class, in particular, the statins have a lot of things for you to know and consider that has been historically known, well established, but also very relevant for clinical practice and also for those of you taking exams. Great test questions here that come up a lot. And then, of course, we'll wrap things up. Okay, so with that, we're going to start talking about the agents. And there's quite a bit of them. And so when you see a drug class like this with a lot of drug therapy options, there's money to be made. That means there's also a therapeutic benefit. Okay? So if a drug class really never develops or goes many places, it's probably because it doesn't do that much and there's less incentive from the pharmaceutical industry to want to go ahead and compete for a small piece of the pie, right? The statins have been around, and some have come and gone. Like, for example, rosuvastatin is listed here. It's no longer on the market, but just for historical context. So we have Atorvastatin, less commonly used fluvastatin and lovastatin. And then we have our pitavastatin, pravastatin, rosuvastatin, and simvastatin. So, and many of those also come in combination of other medications. I'm not going to dive into those right now. There's too many of them in this particular class. But just keep in mind that a lot of the statins are formulated in dosage forms that allow them to be co-administered with other drugs in not only lipid lowering, but other areas as well in cardiovascular related disease that improves compliance adherence, okay? All right, next we're gonna migrate over to the indications and uses in everyday clinical practice. And there's a lot that have evolved over the years, okay? I provided you a list of those, and not to insult anybody's intelligence, I know you can read, but the gist of it is that these are used for primary and secondary prevention of patients with known cardiovascular disease, or also known as ASCVD, atherosclerotic cardiovascular disease. That was specifically more of our secondary prevention patients, but it's also a class of drugs that can be used to manage patients with heterozygous and homozygous familial hypercholesterolemia. Those are patients with a genetic predispositions, right, to having LDL receptors that are non-functional. And so as a result of that, cannot extract out the LDL from the circulating blood that would prevent that LDL from depositing in the endovascular lining. So those patient populations are very difficult to treat, and they develop very early an accelerated atherosclerotic disease that can sometimes shorten their lifespan. So it's very important that we recognize how to treat those patients, okay? All right, now moving on, next is the net benefit. And yeah, I mean, it's huge here, okay? I mean, I don't think I need to state that overly too much here, but statins are well established. The evidence that's available in both primary and secondary prevention is significant. In fact, I'm going to show you some of the landmark clinical trials in primary and secondary prevention towards the end of the lecture that's really important for some of you guys to know, especially integrating evidence-based medicine into clinical practice. Because it's important that we know why we do what we do, and it should be based off something. Now, the other benefit is that this drug class very well targets the LDL parameters of the cholesterol. So if we need to get cholesterol down typically over 50%, we do have some options. Now, not all of them are that same degree of potency, but Atorvastatin and rosuvastatin are high potency statins that can get up into the 60% window from baseline. Now, almost all statins, okay, at the first dose are going to at least offer usually, okay, 30% reduction. They've also been shown to reduce vascular-related events and mortality. Okay, again, that goes back to that primary and secondary prevention. And when you see repeated studies showing the same thing or the same overall pattern, there's truth to that. Now, are all drugs perfect? No, of course not. That doesn't exist. Right? So there's issues, and people want to beat these drugs up, but quite honestly, they do confer a benefit. Now, they also offer what are called pleiotropic effects. And there's a lot of people that use them for that reason. It's not just to lower the cholesterol, but it facilitates plaque stabilization so it doesn't rupture, okay, and initiate the coagulation cascade and platelet activation and aggregation. Has some local anti-inflammatory properties, which an atherosclerotic plaque is largely inflammatory. Those endothelial cells don't want that stuff there. Try to get rid of it, right? There's improvement in endothelial function. What that means is the endothelium of the vasculature is one of the things that makes things like prostacyclin and nitric oxide that have local vasodilatory properties and antiplatelet properties. That's good in patients with vascular disease, right? And then an inhibition of thrombogenic responses. So when you take the totality of the evidence and the ability to lower the LDL and all these other pleiotropic effects, and you sum all that up, there's a general benefit. Now, again, assuming the patients can tolerate it, assuming it's used in the right doses and the right combinations of other medications. Okay, now we're going to shift our attention over to the pharmacology, okay? And in this is where we're going to start diving into mechanisms. Okay, it gets a little complicated, but I also want to put the context of the mechanisms and the targets from a pharmacodynamic effect in the context of other lipid-lowering drugs that are out there. You should not only learn something in its isolation, but how does it compare to other options, and why do I pick one agent over another? Okay, so what I'm providing you here with is a table, and I understand that it is got a lot of text and it's detailed. And you may not be able to fully see it, read it on the screen. And if you're listening to us on our podcast channels, you obviously can't see it. So I'll walk you through it, but it's available for free at download at thisiswhy.health, which is the website for the channel, and offers specific playlists and collections that are not found on YouTube and other places. Things like this where you can download them. It's free. Okay, so please check it out. You can also submit questions and other things there. So there's a lot of benefits to considering that. Now, the table is broken down into targets of LDL that are statins, which is what we're on. Targets of LDL that are non-statins. That class has grown significantly. Okay. And then there are those drugs that target the triglycerides, and then the sort of miscellaneous things like niacin, which we don't use it very much anymore, but still is out there and may show up intermittently, and you need to know why we don't pick it or use it first line. Now, so that's how the table is broken up in the rows. Column-wise, what I try to provide you is the drug class, the example or classic agent. So for example, like the statins up at the very top, because that's where we're at here. We're targeting LDL and the statins. Okay. We have Atorvastatin, rosuvastatin. Those are your high potency statins, getting that LDL less than or dropping more than 50%. So mechanistically, it summarizes it that it inhibits HMG-CoA reductase. It's one of the rate-limiting steps of cholesterol biosynthesis inside the liver, and specifically those hepatocytes. And so it reduces the overall hepatic cholesterol production. So when you reduce the concentrations, you then facilitate the upregulation of LDL receptors. Those upregulation of LDL receptors extract the LDL out of the circulation and prevent it from depositing in the vasculature. That's why it can be helpful in some of these difficult patients, assuming that the LDL receptor is functional and works. But some are better than none, right? And so you see over in the last two columns are the targeted lipid effects. So the first one is the main target. In this case, it's going to be LDL. And we break down statins by high potency versus sort of moderate or high intensity. And then we have moderate intensity statins, basically 30 to 50% reductions from baseline in the LDL. And then we have other lipid effects. What does it do to triglycerides? Which you can see typically reduces them by up to 20% and then raises the HDL cholesterol by approximately 10%. So all the lipid effects that are happening with statin therapy is actually beneficial and good, right? Now, I'm going to warn you on the next image. It's maybe even more complicated than the one I just showed you. Not trying to induce fear, frustration, irritation. That's not the goal here. I didn't create cholesterol biosynthesis. I'm the messenger of it, right? For right now on this topic. Now, when we talk about predominant cholesterol biosynthesis, we're talking about what's happening in the liver. There is a component that happens in the GI tract, and there are drug classes that focus on that, like cholesterol absorption inhibitor, ezetimibe, that works on the Niemann-Pick C1-like peptide, for example, right? Now, I'm talking about once the portal circulation from the GI tract and other things from the blood go through the liver and the hepatocyte are one of the powerhouses for this. It's one of its functions. And so this square that you see up here, okay, represents the hepatocyte, and that's listed here. Again, I know it's very tiny and small, but this is available for you at thisiswhy.health. And the reason I want you to download it and consider it, and strongly consider it, is because you see there's a lot of black boxes with white text. And that represents a lot of the other classes of drugs that make up the category of anti-lipemics or lipid-lowering drugs. And you can see there's a lot. It's growing, especially in the non-statin for LDL lowering. So the statins predominantly work right here, okay? So this is where HMG-CoA reductase is. And that's where the rate-limiting step for cholesterol biosynthesis occurs inside of the hepatocyte. And this is where cholesterol is in the center of it, okay? Now, if you think about bempedoic acid, which is an ACL inhibitor, that's upstream, okay? So that's working on ATP citrate lyase inhibition, another enzyme way up here, but it's earlier in the process. But this whole chemical reaction is the formation of cholesterol inside of the liver. The rest of it is about LDL receptors and also the production of lipoprotein a, okay, which is now growing also in its number of interventions. So it's complicated, and it's hard to fully wrap your mind around all of it, but don't give up on this, okay? I developed this in part because I was having difficulty in its evolution through my training and also as the evidence and the literature evolved on where are these drugs working and how do they all fit together. So if you find this to be helpful, or feel free to share it with your friends, colleagues. If you teach, feel free to use it. It's a tool, okay? But it's a big picture tool that lets you see what's happening. But at the end of the day, if we reduce cholesterol production inside the hepatocyte of the liver, then the body is going to, and that liver is going to upregulate the expression of genes that make the LDL receptor and push them to the surface. And in doing so, it will try to extract out the LDL from the circulation. Again, it assumes that the LDL receptor works, but that's where, remember, the patients with HeFH and HoFH, they have a problem with that. Okay, but if you can get any of them to be there and any of them are working, it's better than none. Once cholesterol is made and it forms VLDL, it then gets combined with ApoB 100. And so you'll talk about that, you'll measure that. There is a target of goals to drop the ApoB levels. So every individual lipoprotein, okay, that's non-HDL essentially, has an ApoB 100 on it. It's a protein, okay, it's an identifier. That talks about our particle count. How many particles of LDL are there, and LDL, or IDL, and VLDL that are out there floating around, okay? And so that becomes very important to understanding the number of particles in solution. That doesn't tell you about the size of those particles. And that's where all this is happening out here. You see VLDL changing in its size to intermediate density lipoprotein, and then LDL, low density lipoprotein. They're changing in sizes and becoming more, changing in its density. And there are some that can become even more dense, small, dense LDL particles. And that has a lot to do with our triglycerides and things I don't have time to go into right now. But our target is to decrease the overall output of VLDL and increase the upregulation of LDL receptors to extract LDL out. In combined effect, you can get significant lowering in the LDL. Now, I've tried to summarize that in this table for you. And I broke down in this particular table, this is looking at the pharmacokinetic and pharmacodynamic differences among the statins. So remember the first table I showed you was just sort of the big picture of statins in general. This is now diving a little bit deeper in the individual statins and their pharmacokinetic and dynamic differences. When I say pharmacodynamic, I'm talking about that biologic effect on the body. What is it doing? Well, remember, we care about LDL. And so this table is organized by, you see up here in the middle, the majority of them make up moderate intensity. And that 30 to 50% is referring to the maximum LDL reductions that you'll see with standard appropriate doses. So they're more of that moderate intensity, moderate potency statin. The high potency statins over here on the far right columns, you see our atorvastatin and rosuvastatin, where you can get above 50% and sometimes even get above 60%. That's why that is occurring from baseline, okay? So knowing your baseline and knowing your target LDL, you can predict what kind of drugs will likely get you there. Now, no matter what drug you use, you're going to get 30% at minimum, no matter which one you use. So you're going to get 30%, okay? Now, what you see in the other rows here are the reductions in triglycerides, for the most part, relatively consistent. Maybe atorvastatin gets a little bit more. You know, increases in HDL. Again, it's good cholesterol. Is that improving reverse cholesterol transport, or is it just a number? Those are two different things, right? But it's not a negative effect. It doesn't seem to be harmful, okay? You can see that plasma half-life becomes an important factor. This actually correlates to when and what time of the day that you take the medication. Because you'll see when we talk about it here in a minute, cholesterol biosynthesis peaks in the middle of the night for people, most people that sleep during the night and are up during the day. Around 2 o'clock to 3 o'clock in the morning is when it occurs. Well, you'll see patients with low half-life drugs, right, short half-lives. We recommend to take it at night so that it's there and in concentrations adequate when that cholesterol biosynthesis would normally peak. Well, when you look over here at the high intensity or high potency statins, they have long half-lives. So long that you can take it in the morning, afternoon, at night, it doesn't matter. It's going to be there present when it matters most, okay? So that pharmacokinetic, that's why it matters to know that, because it correlates to when a patient can take the medication. Why would that matter? Well, because some patients can't remember to take something at night. Maybe it's they get up in the morning, they have a routine, and they take all their medication, and that's the only way they're going to remember it to be compliant. Well, then use a drug, assuming they can tolerate it, that's a high potency statin, gets them the LDL lowering, but it also gives them that pharmacokinetic variable that works for them. Okay, it's also potentially a little bit more forgiving, right? Depending on the time of day. You then see that there are drugs that get renally eliminated, not very much of an issue. Those that can penetrate in the central nervous system, why would I point that one out? Well, there are statins that are hydrophilic and lipophilic. And obviously lipophilic statins, lipid-loving or more lipid-friendly statins, are more likely to penetrate into the brain. You can see some of those listed here, right? Rosuvastatin, pitavastatin, and simvastatin. And so why would that matter? Well, you're going to see later on when we talk about adverse effects, side effects, there's been debate, concerns about changes in cognition. Well, I mean, these patients already have vascular disease or at risk for it, maybe already. And so that's going to be a whammy against that, potentially, vascular dementia. But now we add a drug that could make it potentially worse. And so we want to minimize drugs that would get into the brain. And so your hydrophilic agents, right, are less likely potentially to get into the brain and maybe less likely of that of concern. So that's just, I want you to know the debates. If you search this on the internet and you read about topics, there's a lot of case reports, you read social media in particular, you're going to see all kinds of stuff. Okay, now we know that people can individually experience adverse effects, but the totality of patients on these, that's not the case. Okay, so I'm not saying that you blow it off or ignore it, you just put it in the proper context. Pathways of elimination. Remember, phase 1 metabolic pathways are your oxidative reductive pathways. Those include things like cytochrome P450 enzymes. Phase 2 pathways are conjugation pathways, usually to make a drug hydrophilic so that it can be eliminated in the kidneys and eliminated from the body. And you can see that some of these drugs are using that. I'm going to dive a little bit deeper into those, okay, as we move on. Okay, so here's the pathways of elimination. And again, I broke it down, kept it in those standard sections of our moderate intensity statins in the middle, because they're the majority of them. And then on the far right are our high intensity statins. And you can just at a quick glance see that a lot of these drugs go through multiple pathways, including transporters. And when we talk about transporters, I broke it even down by those that are influx transporters and efflux transporters. Drugs that move, or transporters that move drugs into the cell, and then there's transporters that kick drugs out of the cell and move them into areas, other areas or elimination, right? So when we talk about pathways of elimination, it's not just phase 1, phase 2, but it also includes transporters. And that's important because drug interactions at any one of these locations can cause clinically relevant drug interactions. You'll see here in a minute when we get into the side effect potential, when these drugs cause problems, it is usually due to a concentration dose-dependent effect. Too much of anything is bad for you. Too much oxygen is bad for you. It's toxic. Too much water with no minerals in it's toxic to you. So just because it exists doesn't mean it's, and even natural doesn't mean it's healthy or safe. Everything in too much is a problem. So that's true for statins. And you can see that a lot of them utilize phase 1 metabolic pathways. But pravastatin is probably the least likely to have that issue. But it's not devoid of UGT pathways, phase 2. So there are glucuronidation interruptions that can impact the removal of drugs and cause myositis and or liver issues that you see with patients. UCP-glycoprotein is huge. That's one of our major efflux cell membrane transporters. So is BCRP. There's a lot of drugs that inhibit P-glycoprotein. In fact, drugs that inhibit P-glycoprotein typically also inhibit 3A4. Well, you see Atorvastatin uses 3A4, simvastatin uses 3A4, lovastatin uses 3A4, fluvastatin uses 3A4. So if you have a drug that inhibits 3A4, it's probably going to inhibit P-glycoprotein. Well, if you inhibit both of those with a drug, like amiodarone, for example, you're going to significantly elevate the concentrations of that statin that's trying to go down one of these pathways for elimination. That's why I'm spending the time on it. Now, do you need to memorize every single pathway in here? Most cases, not. Certain exams will test you on some of that. P-glycoprotein is probably a big one. Cytochrome P450 is a big one. As it relates to phase 2, just knowing that it's glucuronidated, right? If you, across the board, except fluvastatin for the most part, and we don't use it, fluvastatin, then any drug that inhibits glucuronidation pathway has that risk. And Gemfibrozil is a good example of that, which I'll talk about here in a minute. So here's the pathway of statin metabolism generically, okay? Generically. So statin up here, right? It goes through hydrolysis to form a statin acid, and then it goes through the phase 1 pathway, oxidative reductive through typically a cytochrome P450 enzyme, obviously. But you see right here, there's glucuronidation pathway. So statin glucuronides are very relevant. Remember, the purpose of a glucuronide is to conjugate it to make it more hydrophilic to help it be excreted. And one of the main ways it's excreted is in the bile. But it can go back up here and kind of recycle itself. And drugs that would impair the glucuronidation would obviously decrease the biliary excretion, which would increase the concentrations of these components and put you at risk for side effects. And one of the drugs that's classically known to do that is Gemfibrozil. Now, not fenofibrate. And so on this particular table, what I'm trying to highlight for you and draw attention to is that you see over on the far left, I have the fibrates effect on the statin levels at Cmax. These are the different statins, okay? They're just all listed there. I've included rosuvastatin, even though it's discontinued. Part of the reason it was discontinued is because of the drug interaction issues and the side effects. But you see here in the middle column is fenofibrate. And while it can inhibit cytochrome P450 enzymes, it doesn't inhibit glucuronidation significantly. And so when you look across the statins, you can co-administer fenofibrate with a statin and not really see problems. When we talk about fibrate and statin interactions, it is hands down Gemfibrozil, hands down. And that has to do with the fact that it's inhibiting not only some cytochrome P450 pathways, but UGT. UGT. And so you see there that with each of the statins, for the most part, there is a decent increase in the concentrations or area under the curve that exposes patients to that concentration. And when that happens, that leads to the side effects, okay? And so these are important components of the pharmacology, includes pharmacokinetics and dynamics, that lead us now into building on that a little bit more in the clinical knowledge and application piece, okay? So I'm going to build on things that I just said. So follow me and stay with me, because what I'm getting ready to teach you and make sure that you maybe already know or reinforce it are things that are highly testable but also clinically relevant for you to understand the proper information so that you can counsel your patients in the proper context of the totality of evidence and also our clinical experience. All right, place in therapy. So we see that this is a first line, and that's a guideline-driven thing, targeted for LDL reduction because we have them, they've historically been around, and they do a good job at lowering the LDL in both primary and secondary prevention. That's key, guys. Primary, which is before the event. You've not had a heart attack, you haven't had a stent, you haven't had a stroke, ischemic stroke. Primary prevention. Secondary prevention is obviously something happened and you're now preventing a second event from happening. So it's more reactive in nature. We talked about statin secondary effects, their pleiotropic properties on plaque stabilization, improvement in endothelial function, things that are going to reduce even sometimes symptoms, because if nitric oxide is more available, prostacyclin is more available, you have local vasodilatory properties, local antiplatelet properties. That's all good. All of that is good at helping to stabilize the membrane. Now, we talked about that moderate intensity and high intensity statins. Now, obviously with most drugs, there's a dose-dependent effect, right? The more you give, the more effect, and then there starts to become a ceiling effect. So these are where we study things in pharmacokinetics like the ED50 and things like that, where the effective dose, where 50% of the patients receive the desired therapeutic response. This is about potency. How much drug do I have to give to exert the pharmacologic effect that I desire to see? So when you look at milligrams in here, and this is a dose equivalency chart that I'm showing you. So how do you convert somebody from one dose of one statin to another dose of another statin? Is basically what you use this for. That's the guide. So it's a tool. It's one of those things that you put in your pocket, and if you do this a lot, and you're learning it early on, this is a good one to memorize, because sometimes you are switching around, or you're on formulary management and you're trying to figure out which drug is going to be the best one for this patient based on the formulary's selective choice for cost savings issues, right? And so the way that you would, utilize that is that you can see the milligrams of one drug and it's equivalent to another drug, essentially. But depending on the type of intensity that you need, okay? And so it just becomes important. So you can see that rosuvastatin is one of the more potent drugs, especially compared to atorvastatin. So if you look, 40 milligrams of atorvastatin is equivalent to 20 milligrams of rosuvastatin. That's how that works. Now, is this a perfect exact science? No. Don't treat it like that. Very few absolutes like that we have. They're guides. It's an approximation. It gives us something to guide us in everyday clinical practice if you find that to be useful. All right, so now, starting doses. Is it necessary to start at the absolute lowest dose? No, most patients can tolerate kind of that middle, moderate intensity dose, okay? And then once you establish them on therapy, right, each doubling of the statin will reduce the LDL by another 6%. And you're like, wow, that's not that big of a deal. Right, you get most bang for the buck on the first dose that you use. If you remember back earlier, I was showing you that most people start on any dose of statin are going to see around 30% reduction, okay? And then from there, the incremental benefit from increasing the dose is still there, but it's not that great, right? Most of the bang for the buck is early on. And the reason that matters is because if you start pushing people to maximum doses that are approved, they may not be able to tolerate it, or you increase the concentration. You're not getting more LDL lowering at that exponential rise. So it is important to keep that in mind in the context of patients, especially if they're experiencing side effects, which, what are some contraindications or warnings? When would you not use these drugs? Well, patients with a very clear history of a muscle disorder, right? You're likely going to exacerbate that in that patient population. Cirrhosis, they have true liver disease. Their ability to metabolize and or their functionality may be compromised. So that includes the metabolism of drugs, okay? Now, historically, statins have been considered contraindicated in special patient populations like pregnancy because the developing fetus, baby, needs that cholesterol for a lot of things. I mean, our brains are made up of a lot of fats and lipids, nerves, axons, things like that. It's very important. Cell membranes, we need that. So historically, they are avoided, okay? If some patients with pregnancy still have vascular disease, what are you going to do? And this is where it gets tricky. And that's where it's good to know what your other options are. But regardless, if you lower LDL, still could potentially harm the baby, right? All right. And then this also includes patients, if you have atherosclerotic vascular disease or patients with familial disease, you still have to keep these things in mind. There's a risk-benefit ratio that you have to just weigh out, and that's not always straightforward. What about breastfeeding? Well, again, drugs that are going to be more lipophilic theoretically are going to penetrate into that milk, and we don't want the newborn to bring that in, because whatever they bring in, they can then absorb into their body, and it causes systemic effect that could affect their growth and maturation. So we just kind of avoid it altogether. Okay. Now moving on to hepatotoxicity. I wanted to show you this diagram, and I want you to stop and just listen to it, look at it for a second, and follow me here, because it's teaching you a very important point, and it overlaps with muscle toxicity and injury as well. Okay, so follow me. What you see over here in the legend represents, based on color and a little icon with shape, for each statin. Okay, so you can see that all the statins are there, and if you look over on the x-axis here, it's about the percent reduction in LDL. So this goes back to that potency. How much LDL lowering do I get with this dose? Now, on the y-axis, you see the risk or elevation in ALT, which is one of our liver enzymes. It only really manifests significantly when there's cell turnover or death. So if you're damaging hepatocytes from drugs, right, and that level gets too high, or a threshold, because we have cell turnover, all of us. So when we exceed a certain threshold above our upper limit of normal, then we know that there's more death and damage to the cell for some reason. That's what the y-axis is. Now, what are these? Like, let's look at fluvastatin, this red line here. Each dot here represents a dose. So as you increase the dose, you see that you're increasing the LDL reduction, but you're increasing the risk of liver enzyme elevation. Well, that goes back to that dose concentration dependent problem with these drugs. We'll look at all of them. So lovastatin, look at simvastatin. Just increasing the dose, yes, you get more LDL lowering, but you also increase the risk of liver toxicity or enzyme elevations. What is this? So this is telling you, number one, okay, write this down. Number one, that it is the risk of hepatotoxicity is dose or concentration dependent. Here's what it's also telling you, very important key, listen, that it doesn't matter, if you look across here, the potency of the statin is increasing as you go from left to right. The potency, the LDL lowering effect. But it doesn't matter. All of the drugs show an increase in the risk of hepatotoxicity with increases in exposure. So it's not about the potency of the drug, it is about the drug concentration, regardless of the potency. That's really important, because some people perceive that, oh, it's more effective and it's more potent, therefore it's more likely to cause liver damage. No, that's not the case at all. It is related to the drug concentration of that drug in the body, in the exposure. The same thing exists also for muscle. Okay? Now, what I've tried to provide you here are some common clinical questions in the form of a table that are based off of really two main organizations that have done an extensive amount of work on this subject. The National Lipid Association and the American Heart Association have both established statin safety task forces, basically committees, to evaluate the totality of the literature and try to answer these questions for us as clinicians. So thank you very much, NLA and HA, right? They did a surmountable amount of work to get us to these evidence-based, basically synopsis. And so I've tried to provide those here for you. But the question about liver toxicity is the take-home point right here. The risk of hepatotoxicity is 0.001%. That's pretty low. Now, this is in the context of standard appropriate doses, no major drug interactions, someone didn't overdose. I'm not talking about that. But what they all consistently see is that there is a dose or concentration dependent effect. And that's why knowing drug interactions makes sense. It's why it matters that you understand the context of dosing, especially with co-administered drugs that are going to interfere. Okay? And so that just becomes relevant, right? There are protease inhibitors that interfere with it. There's diltiazem verapamil will inhibit some of these statins. There's gemfibrozil, bempedoic acid. I mean, the list is so long, it's not even funny. So you cannot ignore it. So there's common questions like here are elevations in liver enzymes associated with statins? Yes, but it's concentration or dose dependent. Are statins associated with elevations in liver enzymes and liver indicative of damage or dysfunction of the liver? No. Do statins increase the incidence of liver failure, liver transplants, and death? It says yes, like, wait a minute, whoa. Yes, but I thought you said it was, well, of course. It can happen if you use it wrong, in the wrong patient. So that's what that means. What about patients who are experiencing basically fatty liver disease? It used to be non-alcoholic fatty liver disease. What about autoimmune hepatitis? Can we use them? Are they contraindicated? I'm sorry. No. Right? Do statins need adjustment in HIV, Hep B, HCV? Yes. Yes. Why? Because those drugs are known to interact, and they can cause concentration-dependent effects, right? So put this in the context of the appropriate issues related to that. Now let's move on to the muscles. This has been a hot and debated area for as long as I've been practicing. And the definitions have been varied over the time. If you read old literature compared to new literature, the definitions of myositis, rhabdomyolysis, all this stuff is all confusing. I hear people tell me all the time, still to this day, oh, the patient has rhabdomyolysis. And I'm like, no, they don't. They have myositis, right? Because people just assume that because there's elevations in CK, it's rhabdo. No, rhabdo, if you look at the definition here in this table, is where you have not only a myopathy, but it is associated with myoglobinuria or acute renal failure or AKI. So you have some renal impairment. But if you just have elevations in the CK, that is a myopathy or myositis, inflammation of the muscle cells that are causing the release of the CK. Now, so this table has been put together to try to give you the more up-to-date, as much as possible, evolution of these definitions so that the organizations that put this together are trying to be consistent amongst us as clinicians in clinical practice, but also clinical trials. And so SAMS stands for Statin-Associated Muscle Symptoms, SAMS, SAMS. And these are muscle symptoms that are reported during therapy. Now you have to decide, does the patient just have myalgia, do they have myopathy, or do they have rhabdomyolysis? Okay, that's what you're trying to discern. And so these definitions are testable. I've seen that. Number two, they are clinically applicable. Okay. Now, going back to who gets it, why, and how, and all this stuff. Again, you see the same sort of effect in the diagram here, that you have a dose concentration dependent effect. It has nothing to do with the potency of the statin. It has everything to do with the concentration of that statin and its risk of elevations in the CK, which would be manifestation of muscle breakdown. And so the NLA and AHA, again, have compiled through the evidence some of these questions that clinicians are trying to answer, like, can statin-associated myalgia be reliably differentiated from placebo? Yes. Is there a reliable score a test that we can do? Yes, and I'm going to show you that here in a minute. Okay. Are statin-associated muscle complaints altered by acute or chronic activity? And the answer is yes. Because if you have an acute change in something, someone took too much, overdose, or started new medication, got a clinically relevant drug interaction, sure. Okay. So those are there for you. This is the tool, risk stratification tool, of the likelihood that you're dealing with a statin-associated muscle symptom, right? And it's the SAMCI, or clinical index. And you can see here that you have different regional distributions of where the pain is, how long it's been going on, symptom onset from the initiation of treatments, were they de-challenged, i.e. did they stop the medicine, did it go away, or did it come back or get worse, right? Did you re-challenge them and see if it came back? It's a complicated risk stratification tool, I'm not going to lie. It takes a lot of time to do it and do it correctly. But down here is where the summation is of the likelihood or the probability that you are experiencing muscle-related problems from this medication. So before you blame it on something like the statin, do this and consider it so that you're not missing something else. And then you lose a drug class simply because, oh, well, statins cause this, so therefore it must be the statin. Well, not necessarily, right? All right, what about the risk of diabetes? So we've talked about liver problems, we've talked about muscle problems, and now we're hitting the other one, diabetes, and the one gets a cognitive. Why is this coming up? Well, in my personal experience in managing these patients, when someone has one comorbidity in metabolic syndrome, they typically develop the other ones in any order. It's like a triad. You have high cholesterol, you'll eventually have high blood pressure, you seem to always develop diabetes or at risk for it. If you have diabetes, you're going to have high cholesterol, and you probably already have high hypertension. I mean, you look at these patients, look in your own patients, think about it next time. When you see somebody with one of those conditions, how many of them also have concomitant conditions with it? And so that triad just shows up. So inherently, there is a risk, lifestyle, genetics, things that you're not going to be able to necessarily fully change. However, there is a meta-analysis that did suggest that there is a risk that statins may do this. But I'll just tell you that number needed to treat is very not significant. Like, you're not going to go stopping everybody off statins because of the concern of diabetes. The overall still net benefit is still positive. Do we even know, like, mechanisms? No one really knows. It's based off expert opinions. Well, that's not causality and doesn't definitively, with good internal validity, prove that. Right? What do you do if someone brings it up? Well, you can weigh the risk, follow their fasting glucoses, follow their hemoglobin A1Cs. If you see it precipitating, and getting worse, and they truly are diet compliant, okay, then maybe you can weigh that risk versus benefit and have shared decision making with the patient. But what I really wanted you to appreciate from this table is that the overall totality of the message of this is it's hard to say how much of a true impact statins are having really on diabetes. The same is true for the cognitive effects. Going back to the pharmacokinetics and dynamics chart that I was showing you, where the lipophilicity, the hydrophilicity of more statins that are more hydrophilic statins are maybe less likely to get into the brain and theoretically less likely to cause cognitive disorders. Are there been reports of cognitive decline on the initiation of statins? Absolutely. It typically is a time correlated thing, but think about this. What if the patient's also stroking and you just don't know it? I mean, I do CT scans on patients all the time in the emergency department and find it commonly reported that, oh, the patient's had multiple microvascular disease or infarcts. That means they've been stroking and they don't even know it. Well, what does that do to somebody over time? Over time, it starts to cause vascular dementia and changes in their CNS and function. And so when you look at the overall quality of the evidence, it is very low. Most of this is based off of expert opinion and input of what to do. Okay? So should baseline cognitive assessment be done prior to starting a statin? The answer is no, but it's based off expert opinion because it's their interpretation of the totality of the data. Are statins associated with negative effects on cognition? Their answer is no, and the strength of recommendation is strong because the evidence doesn't really point to that in a strong indicator. But that doesn't mean there aren't case reports. So guys, it's just like drug allergies and cross-reactivities and things. While the risk may be low for one class over to another, it doesn't mean it's zero. And there is no such thing as a perfect drug. It doesn't exist. Okay? So that's why I wanted you to recognize this. That's why I put this in here, is so that you understand the debate and issues that are going on in clinical practice, but you also learn it in the context of not only the strength of the evidence, but the quality of the evidence bringing this stuff up. Remember, because the only way to prove causality with good internal validity is to do a randomized controlled trial. And that's, you have to have that enormous sample size to probably find a statistically significant difference for causing one of those things, diabetes or cognitive disorders. But again, I do not want to diminish the fact that it can still result in case reports. That's why you have to think, and you need to be aware of the best available evidence and the potential. All right, moving on to some of our drug interactions. So we talked a little bit about this before when I was in the pharmacokinetics, talking about the metabolism, elimination pathways, phase 1, phase 2. I already introduced you to issues related to glucuronidation and Gemfibrozil in particular, right? That's very relevant here. A lot of dose limitations with use of Gemfibrozil. People don't use Gemfibrozil very much anymore. Protease inhibitors for the treatment of HIV. While there's other drugs for HIV now, there are patients still well established on PIs and eventually need to be on PIs. Well, that's what you got to use. That's what you got to use. Well, they cause a lot of drug interactions, not just with phase 1 metabolic pathways, but phase 2 and also transporters. Huge. So the list here, amiodarone, digoxin, cyclosporin, warfarin, all these, there are a lot of drug-drug interactions, whether it's through competition or inhibition of enzymes. These are very high yield for showing up on exams, just over and over, just classic. But it's not the only list. I do want to say that, right? There are some statins that have dose limitations. So I brought this up earlier about diltiazem and verapamil, known to be 3A4 inhibitors of phase 1, right? Well, simvastatin is major dependency on 3A4. So it has a dose limitation of 10 milligrams if you're co-administering it with verapamil and diltiazem. Okay? If you're on amiodarone or amlodipine, ranolazine, it's 20 milligrams limitation. These are great questions, but they also show up in clinical practice. But why also from a clinical practice perspective doesn't matter? Well, it's a medical legal issue. Because if you do create an adverse event, you could set yourself up for potential litigation. This is looking at the protease inhibitors, which is huge. So what you see here in each column is the individual statin or HMG-CoA Reductase inhibitor. And then over here in each row, you see the most common available or historically used protease inhibitors for the treatment of HIV. And again, it goes back to those pathways of elimination, but look at some, remember, so think about liver toxicity, muscle toxicity. I said it was what? Dose concentration dependent effects. Well, look at some of the Cmaxes and AUC increases, 200 to 600%, 450%, 3,000% increase in the area under the curve. 5-fold increase. Those are huge, huge changes in what would be normal exposure of a particular medicine in one patient population over another that can easily cause those toxicities that we talked about. And that's why, again, those charts that summed up the evidence said, yes, there's a risk. Of course there's a risk, but it's a dose concentration dependent risk when used inappropriately. Key context. Okay, now, in trying to kind of wrap this section up on clinical application, like monitoring. Well, you're starting statins to lower LDL, and we talked about moderate intensity versus high intensity, 30 to 50% versus 50%. Well, the only way you're going to know about a percent change is to have a baseline lipid profile. And so you do it at baseline, and then every 3 months to allow full steady state to see if you've achieved that LDL goal. Okay, and then once you get there, then you can get away with, if they're tolerating it, they're at goal, you can do it much less frequent, maybe even once a year. Why would you do a basic metabolic profile or a comprehensive metabolic profile? Well, there's a small risk, like I said, of kidney issues, high doses. You break down enough muscle, okay, you would have elevations in CK. You have to order that separate from a BNP. Right? People would have muscle aches, muscle pains. Their urine's changing colors. It looks like iced tea, right? It's very dark brown. You know, liver enzymes, you'd have to order a CMP, comprehensive metabolic profile, to get the liver enzymes, AST, ALT, ALK Phos, T-Billy. If you want to assess liver enzyme and liver injury, okay? So those make sense. But you sometimes will do them in the context of patients who are having particular symptoms, okay? So I'm a firm believer that we should learn things in the context of the evidence, or at least be aware of evidence-based treatments. The statins have a clear history of supporting evidence where multiple sources of data or studies, again, tell a very similar message and outcome. And that matters, guys. So let's take a few minutes just to briefly look at some of the landmark clinical trials that were used in both primary and secondary prevention of coronary heart disease. All right, so you can see in this table, again, it's available at thisiswhy.health for you. This summarizes the key, and I put the abbreviation of the trial, or the acronym for it, and then I just defined it down here on this row. For those of you that can't see it, I'm just, you know, like the HHS trial, Prosper, Juniper, those kind of things, right? So I define what those stand for in the table as well, just for context. And then you can see that a lot of these studies were done many years ago, right? But you can see that they are well designed, overall large sample size. I did include some other drugs, just so you could kind of compare it with the context of other lipid-lowering therapies, like Gemfibrozil does have a study, cholestyramine, a bile acid binding resin. But you see the majority of these are statins. But when you look at the results, again, these are just the main take-home points, not meant to be a journal club, okay, review. You see a consistent pattern as it relates to cardiovascular events, coronary heart disease, and mortality. This is consistent pattern of reduction, and benefit. And so when you lower LDL, even by other drugs, it seems to confer a benefit in most cases, right? Now, you want evidence to support that. Now, what about secondary prevention trials? So remember, primary prevention is something hasn't happened yet, you're just at risk for something, like an ischemic stroke, peripheral arterial disease, you have a myocardial infarction, or you need a stent that's placed. Secondary prevention is you've already had a heart attack, and now we're trying to prevent you from having another one. You've already had an ischemic stroke or TIA, now we're trying to prevent you from having another one. And you can see that a number, 4S trial, the Lipid trial, Prosper, HHS, all these things that have been done with large sample size over numerous years and decades show the same continued benefit like you see in primary prevention. That's what the totality of the evidence is saying. And that's very relevant, guys. Okay, now let's wrap things up and pull this all together, right? So we have been talking about statins, known as HMG-CoA Reductase Inhibitors. That's your Atorvastatin, fluvastatin, lovastatin, even though it's not used as much anymore, pitavastatin, pravastatin, rosuvastatin, and simvastatin. Remember, rosuvastatin is off the market. Indications, a lot of them, but think again, primary, secondary prevention of cardiovascular disease, and then those patients with heterozygous and homozygous familial hypercholesterolemia. But these drugs are working on that enzyme that is the rate-limiting step of cholesterol biosynthesis inside the liver. So it reduces that intrahepatic cholesterol that causes an upregulation of the LDL receptors that pull it out of circulation, assuming those receptors are functional. Now, side effects. Remember, dose concentration dependent effects on muscles and potentially liver, okay? Clinical pearls. Remember, there's the pharmacokinetic profiles. These cholesterol biosynthesis predominantly occurs in the middle of the night. So you have long-acting statins and you have shorter-acting statins. The longer-acting ones, like atorvastatin and rosuvastatin, can be taken any time of day, but the shorter-acting ones should be taken at bedtime to maximize their effect. But don't forget, statins also not only lower LDL, but they also have pleiotropic properties. Now, lastly, the risk of, again, muscle injury, liver injury is very rare and is really related to inappropriate use or an overdose or increase in the concentrations, usually from drug-drug interactions. Special patient populations, HIV, don't forget, so if they're on PI-based regimens, be very careful, probably need to consult with a pharmacist, ID specialist to make sure that you're not mixing the wrong drugs in the wrong situation here. I've seen that go bad for patients. And then pregnancy, breastfeeding, generally and historically considered contraindicated. Woo, that's a lot, guys. Statins are big. Yeah, that's a lot. And there's a lot to absorb, and that's okay. Don't be afraid of it. I know, especially if you're early on in your training, don't let this overwhelm you. Everything that I just provided you is I wish to God someone had told me these things, when I was starting to learn this stuff. That's all very helpful information. I don't mean to be biased, but I've been doing this for a long time, and I'm a clinical lipidologist in my previous training, and so I have a heart for this, a passion for this. It's important. And so I hope you found it to be useful, but also relevant to what you're doing, what you're learning, and how you're going to take care of patients, even if you see these drugs in environments where you're not necessarily prescribing, but the patients are on them, because, right, they're very common. So please subscribe to my YouTube channel if you haven't done so already. Give us a like, right? Really appreciate that. Check out thisiswhy.health. There's a lot of extra features for being a member. It's free. Our goal is to reach and help people. And feel free to share this information with others. I'm Dr. Busti, and thank you for joining, and never stop learning the why, because that makes the how so much easier, guys. Take care.